Everybody, thanks for joining our Zoom meeting. Sorry we can't have our usual in-person seminar where we have, things to eat and drink and so forth. But in a day of virtual everything, you can enjoy your virtual French toast. I want to thank Marie Deveni, who's Mike Duncan's executive assistant. She's driving this Zoom meeting. In the boardroom with her are Jill Palatucci, our administrative director, and Sarah Pivito, our client services manager. A lot of thanks too to literally a presentation like this for a poo of little brains such as I'm standing on the shoulders of giants. And we're very fortunate to be part of a great hospital where we have very strong infection prevention practitioners, very strong infectious disease doctors, and being part of the Penn Network, we've got a whole host of infectious disease and occupational medicine doctors that we rely on. We meet every week, every 2 weeks to talk about all things COVID. And a lot of what I'm saying is based on the wisdom and the learnings I've enjoyed from some of these other resources that we have. I've also invited a couple of our own doctors from the Occupational Health Center to join the call. Dr. Lappin, I believe, will be on. Dr. Manny, a newer addition to our staff who works at the Student Health Center at Westchester University, should be on. I invited Dr. Strohs. I hope she can join. Somebody's got to run the store. So I think she's actually seeing some patients this morning. Their instructions are, if I say something a little crazy, tell me later, don't embarrass me. If it's really crazy, stop me and make sure that you all get the right information. So with that, let's move forward. Marie, if you can put up the slides and go to the first slide. And actually the next slide. So anyway, talking about COVID, we have to start with a disclaimer about fluidity. And as I say, it's like the weather in the islands. If you don't like it, wait 5 minutes, it's going to change. That's the way it's been with a lot of our COVID advice. Knowledge, the recommendations we get from the county, from the state, from the federal government, the CDC, we've gotten guidance from OSHA, Department of Transportation, our professional organizations, the American College of Occupational Medicine, all changing all the time. So don't be surprised, as I say, if we give you different advice next month, next week, or maybe even tonight. Next slide, please. We have a lot of industries represented on the call today. We're very gratified. Thank you for joining. But as I've been telling a lot of our clients, no matter what business you think you're in, since March of this year, you've all been in the infection prevention and control business. Obviously, we in healthcare have always been in that business, but even outside of healthcare, to varying degrees, you've always been in this business. Every flu season, you're in the infection prevention business. We get calls all the time from companies that say, somebody in the plant had strep, what do we do? How do we clean it? Somebody had meningitis, what do we do? How do we clean it? Who do we isolate? But now, of course, we're in this business of infection prevention in a very big way. Next slide. A lot of challenges with COVID, and we can break them up into what happens for healthcare and non-healthcare employers. For non-healthcare employers, obviously your mission is to protect your workforce, to keep COVID out of your workplace by any means possible. Screening people, histories, knowing that somebody's sick and isolating them, as we'll talk about later. In healthcare, it's kind of the opposite. Yeah, we're trying to protect our workforce, but in many cases, we willingly allow COVID into the workplace. It's part of our mission. Now, not all healthcare offices do that. I want to reassure all of you that we at the Occupational Health Center are using the hospital resources when people are sick, when they have symptoms of COVID. We're only screening people without symptoms. We don't have a way in our offices in Westchester and Kennett to isolate somebody who's sick as we do here in the hospital. So I want you to know that if your employees come into our socially distanced waiting rooms, they're not mixing with anybody, at least that we know is sick. And as we all know, there can be people that have COVID and can spread it before we know they're sick. In healthcare, though, because we do willingly allow COVID into our workplace with the patients we take care of, it creates another special challenge, and that's we have employees here that might have at-risk conditions. Maybe they're over 65, maybe they've got immunosuppressive conditions, maybe they're taking medication that suppresses their immune system. So we have the added challenge of being careful to accommodate certain employees that really would be greatly disadvantaged if they were to contract COVID. Next slide. So we have public health advice, the familiar face of Dr. Anthony Fauci in the upper right-hand corner. I'm not going to try to do his voice, although it's pretty characteristic. But public health advice, generally speaking, is always based on what's the worst possible thing that can happen. Because as I learned early in my public health training, public health physicians treat populations. I mean, you're dealing with populations. You have a disease that might be a low incidence overall, but when you multiply that by the number of people in the population, it could be devastating. So even when the problem is uncommon, as COVID still is generally, you got to try to get everybody to take the preventive steps that will help protect the few that might have otherwise been stricken. And this public health advice is the same, whether you're talking about COVID or you're talking about more familiar things like seatbelt use, heart attack risk factors, smoking cessation, immunizations. Not getting an immunization doesn't mean you're going to get that illness. But if we protect everybody in the population, it means those few that might have gotten it will be protected. And it's the same with COVID. Right now, at least, fortunately, COVID is not that prevalent in our society. But if we don't get everybody to take the preventive steps we need to take with social distancing, with face coverings, with hand washing, with travel restrictions, then it's going to spread farther and wider. Now, we've seen reports from different states where COVID is going up now about people that aren't wearing masks, people that aren't practicing social distancing, and sometimes they get away with it because what any given individual ends up doing depends on whether, as I say here, they live in the world of the possible or the probable. When the prevalence of a disease is low, you're probably not going to get it, but probably isn't the same as possibly. So that's why we want to do as much as we can to prevent the possibility of transmission, even though probably not everybody's going to get it. If you get it, then it's 100% for you. Next slide. I'm going to share some data peeking behind the curtain of Penn Medicine. This is the incidence, the daily census in all the Penn hospitals combined, and I'll show you ours in a minute. But this is all 6 Penn hospitals: Huff, Pennsylvania, Presbyterian, Princeton, Lancaster, and of course Chester County, starting way back March 14th when we first had our admitted cases of people under suspicion. The orange in the bar is people that we think might have COVID because of typical symptoms. Maybe they've come from a living situation where COVID has had a breakout, like at a local nursing home, for example. And the blue ones are ones that have tested positive. And as you can see, since March 14th to just 2 days ago, the numbers have come down. The curve, if not flat, is flattening and actually coming down. We had a little bump a couple days ago in some of these suspected cases, and believe it or not, as we'll talk about in a minute, sometimes the bump in the suspected cases is related to how many tests we have and how quickly we get results back. We have enjoyed the luxury of a test that we can get a result back in an hour for a couple of months, and just recently that came under some limited supply issues. So we're now waiting a little bit longer for the tests for people that are under suspicion. But if you see the blue part of the curve, it's been down and coming down consistently for a long time. Next slide. This is the incidence at all the different Penn hospitals. Our president, Mike Duncan, likes to call Princeton, which is in the lower right-hand corner of the canary in the coal mine. They got hit first, being closer to northern New Jersey, closer to Manhattan. They had the biggest numbers soonest. And as you can see, they're down in even the single digits recently. Chester County in the upper left, we've been hovering in the low teens and in the last couple of days around 10, but it isn't gone. It isn't gone from any of these hospitals. So this tells us it's still out there, coming down, fortunately. Part of that is because some of the outbreaks we've seen at local nursing homes and in other living situations where people can't afford, because of where they live and how they live, to social distance from other family members, we're still having outbreaks. So we're in a bit of a summer lull. We hope it continues. As we'll talk about later, there could be some other issues in the fall, but this is where we are now. Next slide, please. This slide shows you the admitted cases, similar picture, all the different hospitals color-coded. Chester County is the green at the bottom, coming down, but kind of on a plateau lately. Number of cases on ventilators has also come down. This is really good. As a lot of you know, we had great fears early on about limited numbers of ventilators. In fact, we had to send 10 ventilators up to Princeton when they were getting hit hard. So ventilator cases are coming down and the mortality is coming down as well. You can see here on the graph, again, Chester County is green. We haven't had a mortality in several weeks. Still getting a couple at Lancaster General and at Princeton, but over here, overall mortality has come down. And as I say, I think this is why we feel comfortable going green. Next slide. These are the ins and outs, and this is the reason the overall numbers have come down. Generally speaking, we're discharging more than we are admitting. I said the last couple of days we've had a little bit of a spike, and this is the whole Penn system again, which includes Lancaster, and they've had their numbers go up. But overall, many days we're discharging more than we are admitting. On June 9th, we admitted 20 and discharged 44. Some of those discharges, regrettably, are people that have expired, but most of them not. As we just saw, the mortality is coming down. Next slide. These are the ins and outs for every individual hospital. And as you can see, 2 days ago, we admitted 1 and discharged 2. So that's a good pattern that we obviously want to continue. Princeton, 2 days ago, had 1 more admission than discharge. Lancaster was about even. So as you can see, decreasing, maybe a little bit of a flavor of plateau in all of these data. Next slide, please. And I'm not sure how well this is projecting, but this is a slide that shows admitted cases at Chester County on the bottom, and for the whole county. Now that's not the Penn system anymore. It's all hospitals in Chester County. That includes us, Phoenixville, Jannersville, Brandywine, Paoli, and I think that's all 6. So again, admitted cases, hospitalized cases coming down. Chester County, as we already saw, is coming down. The trend line is very good. Next slide, please. Oh, that's a better view of it. Okay, so there you can see all the hospitalized cases in the county have come down. A little bit of an increase. I heard from one of my colleagues that was at Brandywine. Brandywine has had a little bit of an uptick recently. We've been hovering again in the low teens, as you can see in the bottom red graph. Okay, next slide. So there's been a lot of talk in the news about case counts and what do the case counts really mean? Are they misleading? Do they really just reflect the availability of testing? Are they not a good indicator of how well we're doing, because the more people you test, the more cases you diagnose, doesn't necessarily reflect more severity. It is confusing. I just heard a report on the radio this morning, didn't have time to get it into the slides, that in Georgia, where there's a lot of talk about their recent increases, there's even some question that they were counting wrong. Some of the cases that were counted may have not been only the diagnostic, so-called molecular test, the viral test, but may have included antibody testing. And if they counted both of them, some of those were double counted. So testing is a bit of a hot mess at this point. As I say here, if you don't have a test, you don't have a case to count. You can still have somebody who's sick, but they don't get officially counted until they're tested. And similarly, you can't have a positive test unless there's a case to test. Generally speaking, case counts will usually underestimate the really true incidence of a disease, because a lot of people have the disease and just don't get tested. As we know with flu, as we know with a lot of other infections, you can have people that have it and have no symptoms. They'll never get tested, but technically they did have it and they would have gone into the case count if they were tested. If we have more available testing, we may do more testing of the general population just to see how many people have it, what we call the prevalence in public health. And cases that still occur might not get tested because testing wasn't available. I know of a couple cases, a couple people in my family in New York early on had very typical symptoms. Well, maybe it's a flu, maybe it's a cold. Then it's like, hey, I can't taste. It's like, uh-oh, I think that's COVID. Went to get checked. Their oxygen level was okay. And the provider said, we don't have enough tests. You're getting better. No test. So anyway, you have to track something. So we track the case counts. But when you get a positive test, as I say here, it reflects the whole spectrum of severity. Somebody that shows up unexpectedly, and we're testing more people as tests have become more available. Some of our clients want tests in the pre-placement scenario. People that are coming into work, they want to know, are you free when you come in? That at least sort of level sets that, and we can know if they get sick later, we might have an easier time tracking, doing the tracing on that person. Some people are being tested now pre-procedure here in the hospital. When we started doing elective procedures again, when the state lifted that prohibition, we said we're going to test everybody that comes in to be sure they don't have COVID, because if they do, we got to put them in a special room, use special equipment. If they're getting surgery, we use a special HEPA filter on their anesthesia machine. So we're testing everybody that comes in the hospital for elective procedures now. And we're going to get some positives that we didn't expect. Some of the people we test were mildly ill, they recovered at home. Some were more severely ill. Maybe they went to the ER, still recovered at home. Some were hospitalized, didn't have to go to the ICU or got discharged. Maybe they were in the ICU, not on a ventilator, maybe on a ventilator, and unfortunately, maybe some died. But a positive test in a case count will reflect all of these people. And that's why it can be misleading when you're looking at severity. Next slide. So if we're looking for a reassuring barometer, yes, more testing does naturally lead to more cases because the virus is still out there. If you test for it, you will find it. So if you eventually find a lot of positives in people that never got sick, this is actually somewhat reassuring because it tells us that the mortality rate, or what some call the case fatality rate, is lower than we thought. Current estimates are 0.5% to 1%, which is about what flu is. We thought it was much higher early on when we weren't doing as many tests. Now that we're testing more, we know that a lot of people that didn't think they had it did have it, and that makes that denominator bigger. So we know that the number of people dying is a percentage of a much broader base of people that barely got sick. So we know that the number of people with it that die is lower than we thought. We look at our hospitalized cases every day. We look at our deaths every day as indicators of the incidence and prevalence, but sometimes that's skewed. I mentioned a couple minutes ago that Brandywine hospitals had more. We've had more cases earlier in the pandemic from some of the local nursing homes. So socioeconomic status affects it, people that live in more crowded conditions, as has been happening in the southern part of our county, that changes it. Number of people that live in congregate settings like nursing homes, that can change it. So if you see a spike at a particular hospital, it may be influenced by their local socioeconomic conditions, by their local demographics. However, I think we can all agree that if the case counts go down and the testing is unlimited, or at least there's enough tests to go around, that I think we can at least count as encouraging. Next slide. So I'm actually not allowed to say the word that's underlined and italicized there. I've said it 77 times in June, and that's my whole stock for the month, so I can't use it again until July. But that's the word that people are often using when they talk about these times. A lot of comparisons, but I really think in my life and times, and my life and times in healthcare, which is actually, I'm embarrassed to say, several decades long, I've never seen anything like this because of the multiple impacts that it's had. Some of these have always been present in pandemics, but it's more illuminated now. So this is not just a healthcare disaster and an economic disaster, but recently and more brightly illuminated has been the connections to health equity disparities in populations that have traditionally been disparate in terms of their access to healthcare. But now it's more illuminated, even though COVID doesn't respect any ethnic or racial boundaries, it has a predilection for people of color and people that are poor. And that's the same with a lot of infections, but with COVID, as I say here, it's much more brightly illuminated. Next slide, please. As I said, there's a lot of comparisons around. Here's just a quick slide. I don't expect everybody to read all this. I'm not going to read it all, but we always compare COVID to 1918, the H1N1 Spanish flu pandemic that killed almost 700,000 people in the US. Now we compare that to the over 100,000 people that have died from COVID and are still dying and will continue to die if we get more surges. We certainly hope and pray that we never get close to this figure of 675,000. We've had some other remarkable pandemics in the 20th century. In 57, We called it the Asian flu because it was first reported in Singapore and later Hong Kong. I have early memories of the Hong Kong flu. That killed over 100,000 people in our country. In '68, we lost another 100,000 to an H3N2 flu that we had circulating then. H1N1 and H3N2 are now included in our usual seasonal influenza vaccines. The big one we remember, another H1N1 from 2009, this is only 11 years ago. We thought this was going to really be the big one, a big pandemic. And the reason it was so remarkable is that it had a predilection for younger people. And the theory at the time was that since this was the same sort of subtype as the one from 1918, people in their 60s and 70s and 80s may have had some antibodies from flus that were circulating earlier in the 20th century. So fewer people over 60 were affected and died than people that were under 60 and under 65. Fortunately, the deaths in our country were limited to under 13,000 as we were able to control this, but it was a scary one because younger people got really, really sick. But the overall numbers were nowhere near the pandemic levels that we had earlier in the 20th century and that we feared for this one. Next slide. All right, talk about a little bit about what I call COVID-19's cuz. The first SARS-CoV didn't have a number, we just called it SARS-CoV, hoping there would never be a number 2. But this was the coronavirus that we learned about in 2003 that we named after the syndrome it caused, severe acute respiratory syndrome. That's where SARS came from. We know it was caused by a coronavirus. Another cousin is our favorite common cold virus, the rhinovirus. This spread to 29 countries and regions all over the world, so that's why we call it a pandemic. In North America included, there were some notable cases, some of you may remember, in Toronto, where people that had traveled from the East had brought it back with them, but also South America, Europe, and Asia before we finally contained it. There were no deaths in this country, fortunately, 774 deaths worldwide. Over 8,000 people had probable SARS. The testing was not as good. What was remarkable about this disease was its seemingly high fatality rate, almost 10%. Again, compared to 1% or less for this COVID. The reason it was different is that it caused more of a lower respiratory syndrome. So it probably wasn't as easy to spread as this COVID. Still can spread by coughing, sneezing, and so forth. And people got very sick, and a lot of them did die, but wasn't as easy to spread as this COVID. There was no treatment. The vaccine efforts were shelved after we contained it. Nobody wanted to invest in that. Unfortunately, for the last 16 years, no cases reported anywhere in the world of this SARS. Next slide, please. One of the things I've been talking about lately with some folks is the comparison to HIV in the way we are approaching protection against COVID. I'm old enough also to remember when HIV first came around, and of course this was a bloodborne pathogen like hepatitis B and hepatitis C, spread by blood and body fluids, not by droplets and aerosols as COVID-19 and influenza are. So we initially took precautions against HIV when we knew people had it, then the gloves came on. Later on, we changed this to what were called universal precautions, where we assumed everybody and anybody could have it. So we treated all blood and body fluids as potentially infectious, which meant gloves all the time. And as I say here, can anybody remember a quaint time before gloves were standard equipment in healthcare? You remember a time when you would get blood drawn and the person wouldn't wear gloves? I certainly remember it. I used to get blood from people, put IVs in people, didn't wear gloves. Just wasn't done. We'd wash our hands, but gloves weren't universal. Similarly for COVID, and this is the reason we had problems early on in the pandemic, we were only using PPE, personal protective equipment in healthcare, for people we knew or strongly suspected to have COVID. So people that didn't have it, no PPE, or just standard gloves because of universal precautions for blood and body fluid. Well, we had some pretty bad exposures then to employees that ended up being furloughed or quarantined, and they were out of the workforce. A lot of them mostly didn't get sick, a few did. But we went to the same type of HIV approach. Let's assume anybody could have it. And we know now that people can have no symptoms, but still be carrying COVID and shedding COVID for 48 hours before they get sick. So we assume that anybody who's coughing, sneezing, laughing, singing, shouting, or even just talking around you could have it and be spreading it. Now we have face coverings for everybody, along with distancing and cleaning. We're not really as concerned as much as we were initially about living on surfaces. Yes, we know that you can find viral particles on surfaces far away from where the coughing occurred. Not so sure anymore if those are really infectious, but again, back to the fluidity disclaimer, maybe it's going to be a different story tomorrow. Next slide, please. So essentially, going forward in this presentation, it's really crowdsourced. We've gotten the material for this, most of this presentation, from questions a lot of you have been asking us. Individual emails, we've been sending out a couple of constant contact emails. We've gotten some questions back. Some people have called. We've had meetings, virtual meetings usually. But usually the questions are about cleaning. How do we clean? When do we clean? There were some companies early on that as soon as there was one case in the company, they shut it down and cleaned the whole company, cleaned the whole plant. Not doing that anymore, fortunately. Questions about screening. Do we check temps? How do we do it? Do we check everybody? Do we ask questions? What about face coverings? One of my employees is positive or was exposed to somebody who was positive. What do we do? Do we test? Viral test, antibody test, and when can people return to work? Fortunately, most of the answers to these questions are out there on the public health websites, whether it's CDC, state, or even our county website. We're going to go into some specific scenarios here, but I would always refer you to the CDC and the state for answers about these questions. Again, what I'm saying now is a snapshot that could change in terms of public health advice very quickly. Next slide, please. So one of the frequent questions we get is somebody who was exposed. And I got a question last week. An employee from one company met with the safety director of another company, ironically a safety person. The next day, they heard that that safety director had symptoms and tested positive. What do you do with this person? Well, I first asked, was it a significant exposure? Did it occur within the time frame? And in this case, it did. The person got sick the next day. So yeah, time frame, it's significant. How close were they? Were they both wearing masks? Well, yeah, they were both wearing masks because it was only last week and everybody's masking now, but we're still nervous about it. Let's get them tested. And we did. When can they come back to work? They'd already kept the person out of work and had planned to keep them out 14 days. The CDC and the state do allow some people who are exposed only and not sick to come back sooner if they're considered a critical infrastructure worker, and those definitions are online. Healthcare workers certainly are in that category as well. If they're only exposed and they have no symptoms, they can go back to work immediately as long as they're wearing a mask and the screening is not just temperatures, but symptoms, travel history, that kind of thing. Next question, next slide rather. What about the testing? One of the problems with diagnostic testing is also called the molecular test, the viral test, the PCR test. PCR stands for polymerase chain reaction. It's a test for the virus itself, pieces of the virus that are back in the throat, in the back of the nose, in the upper throat. If somebody has no symptoms, we'd like to know that there's a Goldilocks just right window, but you can be testing too soon or you can test too late. If you test too soon, it can be before the virus is detectable. If you test too late, you've missed the opportunity to keep that person home and away from everybody else to whom they might be able to spread it. If you test really late, like just to see did they have it, that could be confusing too, because we know now that people that continue to test positive on the diagnostic test have pieces of the virus, but they're not infectious anymore. And we know that because we've correlated those later tests with culturing the virus, actually trying to grow the virus in the laboratory. And if you've got a positive test 3 weeks out and we culture it, there's nothing that grows. The virus is not there to grow, so it's no longer infectious. It'd be great if we had a world where testing were not the finite resource it is, and if testing turnaround was always quick, Maybe we do multiple tests. So we say, all right, let's test them at day 3. That's probably the earliest they could become sick if they were exposed. And then if they're negative, let's test them again at day 5 to 7. Maybe that's the fat part of the curve where most people that are going to get it, get it. And then the lower part of the curve, down towards 14 days, if they tested negative at day 3, day 5, we'll test them again between 12 and 14 in case they're a later converter. But testing is still a finite resource. Some employers, and this has been talked about in the lay press as well, would almost want to test every day. If we had a test that could give you more or less instant results, wouldn't it be nice to know every day that every person coming into your plant is negative? Yes, it would be great, but we don't have that resource right now. The only thing we have are screening by what I call the surrogates, the temperatures, the questions, where have you traveled. That's the only thing we can do because testing is still a finite resource. Next slide. I found this on Harvard's site. They had a Q&A talking about the best interval for testing. And I thought the way they worded this was really a little clearer in terms of making the point. And the question was, what are the chances that if I have a COVID test, it'll be negative when I'm really infected? And what they said was it depends on the type of test, obviously the swab versus the antibody, but also on when you test. And what they said was you're going to get a false negative all the time if you test the day you're exposed. So the example I gave of that person that was working with that safety manager, if they found out the next day that the person got sick and tested that day, would have been negative, almost always. If you test after 4 days, well, you're still going to have a lot of false negatives, but now you're getting closer to that fat part of the curve, so maybe only a false negative 40% of the time. And then if you get symptoms, the false negatives go way down. Especially if you wait for 3 days, then it's only 20% of the time. And at that point, it's probably because the swabbing wasn't done correctly, or maybe just the methodology, which always has false negatives, showed one there. So this is the reason we isolate people, even with a false negative, if we think they have symptoms that could be COVID, or if they've been exposed to somebody who had COVID. We keep them home, again, unless they're a critical infrastructure worker or a healthcare worker. Isolate them, even if they test negative, because they still could have it. Antibody testing, we'll talk about in a minute, that doesn't become positive for several days, sometimes even weeks, and sometimes those are all false positive. This is why it's not a diagnostic test. Next slide. A lot of questions from companies about antibody testing, partly because of the sense that we heard about probably in April and May, not hearing about it so much now, that if we knew who'd had COVID, we could identify this COVID elite workforce. People that now we know they're immune, they're not going to get it, we can put them in harm's way. Not really true, at least we don't know that it's true right now. The phrase we use is antibody testing, as a general rule, is not really ready for prime time. There's a lot of tests out there. A lot of them have been given emergency use authorization by the FDA. They're not all created equal. Some are more valid than others. There are false positives, there are false negatives. If it's positive, we're still not sure that it means you're immune. And if you are immune, we're not sure how long. We don't test for influenza antibodies every year. We know they're there, but they're going to be temporary. These might be the same way. Some estimates say they might be there a couple of months, maybe as long as a couple of years, but we just don't know. And we certainly don't know enough to change our behaviors in terms of prevention. We're not going to say, hey, you've got antibodies, get out there and work with anybody, no mask, no precautions. Very imprudent to say that. We're still using it as a research tool. It may give us some idea of how prevalent the disease is in the population. At some point later, if we're better with the testing, we know what it really means, we may use it the way we use tests like antibodies for measles, mumps, and rubella. In healthcare, you can't get a job in a healthcare institution unless you've got antibodies for measles, mumps, and rubella, or hepatitis B, that's the HBV, because those give you durable immunity. Varicella, chickenpox, durable immunity. Not so sure about coronavirus yet. Next slide. What happens if one of your employees tests positive? Now, that's not just somebody who's exposed to a positive. This person has tested positive. The first question is, how did the test come up? Was it just a random test? They were curious. We've had, as I say, employees tested because it's a pre-placement setting. We've had one employer that was having a meeting and everybody coming to the face-to-face meeting, wasn't virtual, had as a courtesy, had been tested, so they were going to get tested too. If some of them shows up as having it, but they're not sick, what do you do? So it really makes a big difference whether the person has symptoms or doesn't have symptoms. If they don't have symptoms and they test positive, isolate for 10 days from the test date, assuming they don't get symptoms in the meantime. If they have symptoms, we isolate until two things have happened. They've had no fever for 3 days, and that's without taking Tylenol or Motrin or any other fever-reducing medicine. The respiratory symptoms, such as cough, have improved. They can go back to work if they're coughing, if the cough is now dry. Even though they're wearing a mask, it's an extra precaution. We all know that some people have what I call those below the nose moments, walking around like this. And at least 10 days have passed since they first had their symptoms. So no fever for 3 days and 10 days since the symptoms first began, they can come back to work. However, there are exceptions again for healthcare workers, and the CDC has made this specific exception for healthcare workers because we feared early on in the pandemic that there could be shortages of healthcare workers that we would need to help fight the pandemic when these very dire predictions about we'd have 500 people in the hospital, 100 on ventilators. Fortunately, thank goodness, none of those came to pass. Got close in some places like New York, but didn't really come to pass. So anyway, the CDC put an exception in for healthcare workers. Once they're not sick anymore, they can return to work, but put them in a job where they're not around patients, not around staff. Maybe they're in an isolated office doing Zoom presentations. Next slide, please. For healthcare workers who are positive, the CDC and the state have identified different strategies. Symptom strategy, we've just talked about, no symptoms for 3 days and no fever, and then symptoms have been around since 10 days. But there's also something called a time-based strategy. 10 days since the test in people that haven't had symptoms, and then if symptoms develop, we use a symptom strategy. Then there's also something called a test-based strategy, which has kind of fallen out of favor. And this is where they said you can go back to work when you've had 2 tests in a row, at least 24 hours apart. These are the diagnostic tests, the swabbing tests. You can go back after you've had 2 negative tests 24 hours apart. This has kind of fallen out of favor because now we know the virus can hang around longer. They can keep testing positive and not be infectious and not be ill. So we're using more the time-based strategy for people that have never had symptoms. Next slide. How about somebody at home is sick? You're okay, but you've had somebody at home that's sick. The CDC says caregivers can leave home, go back to work, back into the world, 14 days after their last close contact with the person who's sick. 14 days after the person who is sick meets the criteria to end their home isolation. So math has never been my strong suit, but I'm thinking this could be a long time, even up to 24 days. So say the person at home was sick. They are now at a point where they've been without a fever for 3 days. It's been 10 days since their first symptom developed. They can go back to work. But the person living with them, the clock starts then, because that's their last exposure. They probably had their last real exposure days before that. They're using an abundance of caution. We go 14 more days. So exposure because of household members, longer. Next slide. We're doing a lot of testing now, and this is the interpretation we put when we report to our employers on what the test means. For the diagnostic test, we have a lot of caveats and disclaimers in here because a negative isn't always negative and a positive isn't always positive. So we use words like usually. So a negative test will usually rule out that somebody currently is sick. False negatives can still happen, but they're unusual. But a negative test doesn't definitively mean there's no infection because there can be false negatives, especially in somebody with symptoms or significant exposure. So if that person tests negative, they still stay home. Also doesn't mean you can't get infected later if you have a negative test now. So you retest these people if they have symptoms later or significant exposure later. Positive test, again, usually indicates that somebody does have the infection now, especially if that person has symptoms or has had a significant exposure, but it can still be infection even without symptoms and without an exposure. It can still be a false positive, but that doesn't happen too often in the testing for the virus. The retest, as I've already said, can remain positive for several weeks, but the ability to spread it will stop probably after 14 days. And if you do test positive, you've obviously got to follow up with your physician and follow the guidelines for isolation, quarantine, and return to work. Next slide. The antibody test, we have other interpretive guidelines here. Again, usually, I'm sorry, previous slide. Usually rules out COVID prior to the time of testing. Again, the antibodies get positive later. So I'm not going to read this whole thing. It's the usually, again, and not always, because there could be false positives. Next slide, please. A couple specific questions we've gotten, and I'll call these now. This is the part of the COVID in summer part of the talk. Questions about turning on fans in the workplace and the use of shields rather than masks. So in a closed space, fans circulate air, but the problem is in that closed space, that air might have COVID in it, and that's why it could be scary. That's why we titled this Scary Masks. But we've also had some really hot days and are going to have more hot days as the summer goes on, and the masks are making the workers hotter. So the question we had was, can the masks come off? Are face shields just as good? Because there was unfortunately some guidance from the state that face shields were a reasonable alternative to the masks. Good news about face shields is they're open at the bottom and along the sides, so there's more ventilation. Bad news is they're open at the bottom and along the sides because the ventilation could carry COVID into your breathing zone. So the question was, can we turn the fans on? Do we go with the shields or not? Next slide. This is just another little reference to scary fans of another type for sporting events and large gatherings, wondering if we'll ever be able to yell at umpires and referees, sing along at concerts, all these other ways to just blow air around, but that's a story for another time. Anyway, just want to let you know there's different types of scary fans. I really missed the live presentations. I hope there'd be a couple of laughs there, but you never know. Next slide, please. We're going to talk a little bit about one of the tools we use in occupational medicine, and it's the discipline of industrial hygiene. I had to study this during my training for occupational medicine. Industrial hygiene is its own discipline. We work with industrial hygienists a lot. And they have two different types of controls that they call the hierarchy of controls. The highest art is engineering controls, and this is where you engineer the problem out of the workplace. You engineer it out, there's no problem, there's no hazard anymore. Sometimes if you can't engineer it out, you can modify the process or at least control it. Now the lower art is what they call administrative controls. You use these if you can't engineer the problem away, and PPE is an administrative control. It's like, I can't make the hazard go away, so I'm going to give you a mask or a respirator. I can't make the hazard go away, so I'm going to make sure you only work in that area for 2 hours at a time. I can't make the hazard go away, so I'm going to test you to see if the hazard is affecting you. So let's use a common example, next slide, for something like noise control. So the objective here is to prevent what OSHA calls NIHL, noise-induced hearing loss. So engineering controls, highest art, can we replace the thing that's making noise? Well, maybe yes, maybe no. If we can't replace it, can we isolate it? Can we put sound absorbing material around it so it's not as noisy? You do what you can in these areas. If you can't get rid of the hazard or isolate it sufficiently and the noise levels are still over 95 decibels for an 8-hour average, then you pull in administrative controls. The PPE in this case is not a respirator or a mask, but hearing protection. It might be the plugs, could be earmuffs. Job rotation, it's like this area is too noisy, we can't control it. Even though we're giving you hearing protection, we're not going to let you work in that area longer than 4 hours at a time. OSHA uses 8 hours as the time-weighted average for what they typically consider a full shift. But if we put you in there for a shorter amount of time, we're going to reduce the hazard. And then again, medical surveillance. So again, we can't control the hazard, we can't reduce it. We're giving you PPE, we're rotating you, but we're also going to check your hearing. And as I said, medical surveillance is a way to use the worker as a hazard measuring device. So if people are still getting noise-induced hearing loss, despite all these measures, you got to go back and do more in the engineering controls, check the hearing protection, make sure that its noise attenuation rating is appropriate for the level of noise you have. So that's what we do for noise, but I want to say that we're going to use or try to use the same method for controlling COVID in the workplace. Next slide. So this is just a graphic representation of what we did for noise. And I'm making up these numbers, but it's going to be useful when we try to look at COVID. So for noise, on the y-axis, we have the likelihood that noise-induced hearing loss is going to occur. And we're going to just say, for the sake of argument, that if we do nothing, that it's a total crapshoot. The risk is, let's say, 50%. Not everybody's going to get noise-induced hearing loss, but if you don't do anything about noise control, don't use earbuds, don't use job rotation, maybe 50% are going to get it. Now we start using some other administrative controls. We give them hearing protection. Well, maybe it drops to 40%. Now we job rotate. Well, maybe it drops to 30%. We isolate the machine. It drops to 20%. We replace the noisy machine and it goes to 0. So that's the kind of scheme we use here when implementing controls in a workplace to try to mitigate or eliminate a hazard. Now let's talk about COVID. Next slide. Talking about fans in this case. So we know we're supposed to distance for 6 feet, and that's based on how far typically a droplet will go with a cough or a sneeze. But we do know now that some of these droplets and even some of the aerosols generated that can carry COVID are going to go beyond 6 feet. And if you turn a fan on, it makes sort of hopefully some logical sense based on physics that you're going to spread it farther and wider. So that's the rock. But for the hard place, you got the heat stress and people that are really uncomfortable in the masks. And if they get really hot and you can't turn the fans on and they're wearing the masks, it might be beyond simple discomfort to really severe heat-related illness like heat prostration or heat stroke. Next slide. So how do we implement engineering controls? Can we engineer COVID out of the workplace at this point? No. The virus is still circulating in the community. And some of that community, as I say here, is still coming to your workplace every day. So we got to go with administrative controls, which is, again, is the lesser art. So we screen people. We check their temperatures. We check for symptoms, ask about contacts, ask about travel. We cover their faces, try to keep them apart at work, do enhanced cleaning and disinfection. Medical surveillance, we're not really doing that yet. Maybe in nursing homes because the state said to do that. Not doing it universally. Some companies may start random sampling of testing once tests are more available, but of course they're still constrained. Even if we get to the highest order of screening, daily tests, every day, every person, still going to miss people. Next slide. So let's look at that same kind of graph that we use for noise for COVID. So let's just say the likelihood of virus spread, again, a made up number. Let's say it's 10%. It's probably closer to 5% based on what we think the prevalence is in our community, but we'll just say 10% for argument's sake. So if we do nothing, no screening, no facial coverings, no attempts at all to figure out if people have traveled somewhere dangerous, let's say the risk is 10%. Now we implement one level of control. We're asking people questions and we're checking their temperatures. Maybe the risk comes down to 8%. Now we go to another level of control. We're covering their faces, the risk comes down to 5%. And again, made up numbers. Now we implement social distancing, the risk comes down to 2%. And if we ever get to daily testing, maybe it comes down to less than 1%, even close to 0. That's the ideal scenario. Next slide. We have to also make sure we know about absolute risk and relative risk. So if the absolute risk in the community is 5%, that's low, 5 out of 100. But at this point, we don't know who those 5 are, and some of them might be coming to work. So the best we can do is reduce the relative risk. It's still possible somebody can come in with this, but if we're screening and using face coverings and social distancing, maybe we're only going to find 1 or 2 of those 5 and keep them out of the workplace, and that's going to be a positive effect. So we're making an already low risk a little bit lower, but of course we want to drive it as low as we can. Next slide. So what happens if we turn the fans on? And what we've done essentially here is we reversed the benefit of distancing. But the point I want to make here is we don't go all the way back to zero, because we're still doing other things. We still have masks on. We still are doing the temperature and the symptom screening. So it isn't like we've thrown all caution to the wind of the fans. We're just reversing the effect of distancing, because now instead of being 6 feet apart, you're right next to each other because the fan blew the particles in your way. Next slide. However, it still begs the question, if you're wearing masks, what are we sending farther and wider? And is it really circulating into that person's nose and eyes and mouth if they're wearing facial covering? So how much are we really circulating because the incidence and the prevalence are low and because they've got masks on? So because you're controlling the source with masks, even if you turn the fans on, you're going to cover some of those sins. However, we still told them we don't recommend putting the fans on, because from a risk management perspective, how can I tell you to do something that could increase the risk for COVID, at least theoretically, even if it's only a small increase? Next slide. So what I said was, you got to balance everything. You got heat stress on the one side, that's your rock. The hard place is the COVID. We can't engineer the problem away. We're going to try to use administrative controls, social distancing, even if the fans reverse the benefit. If you're really risk averse, don't turn them on. But if you got heat stress as another threat, you can roll the dice here, since it probably isn't going to increase the absolute risk all that much, because A, you're using other controls, and B, the incidence is still low. Now that could change in the fall. We got hot days in September, and maybe we've had a surge. Maybe the advice would be different. Again, fluidity. If we could use fans to pull air out of the workplace and vent it outside, that's the best case. But most times we're talking about closed spaces where the air is being circulated inside the plant. We also told this company to think about other administrative controls, like the job rotation, in and out of the hottest areas. You can have special rooms where people go to get cool. You could have cooling vests, which some people have been trying. And of course, breaks for hydration. Next slide. Shields, a similar story. I reversed some of the different hierarchy of controls here. In this case, the shields are reversing some of the benefit of the masks, but again, we're not going back to as if there were no controls. It only reverses one of the controls. You still have the other things in place. Next slide. So they're going to reduce the benefit of the coverings. Fans reduce the benefit of distancing. Shields reduces the benefit of coverings, but the risk, again, is still low. And the risk is a little bit higher than if you were using masks, but again, not all the way back to as if you were using nothing. Next slide. So what he told this company was, all right, the employees are complaining, it's harder to breathe, the masks are damp with our sweat, they're fogging up our safety glasses. And in this particular company's case, HR and their legal department asked for our opinion. And what we said was, we can't efficiently say to use shields instead of masks. It's a lower level of protection, but you as a company have to assess all the risks and try to balance them. Heat stress is a legitimate risk. A fogging safety glasses or goggles is another risk. You got to use your judgment. Face shields are still going to protect against big droplets, close up, but they're not going to protect against everything. So maybe you can use them judiciously in locations where maybe the overall prevalence is low and you've got other mitigation strategies in place. I can't say to do it, but you've got to make a decision to modify one mitigation strategy to mitigate another risk, in this case, heat stress. Next slide. A lot of companies have been asking about travel, whether it's business or personal. If you look at the CDC website, you won't go anywhere. They've got a map which you can look up. The whole globe is red or orange, which is level 3, which means the disease is everywhere. You can get it anywhere you go. If you fly on a plane, it's hard to distance, obviously, you got to have masks on. If you ride on a train, depending on where you're going, obviously similar to planes, but maybe you're taking a longer ride because you don't want to go on a plane and be at an airport, so maybe you're exposed longer. Car trips might be the safest in terms of your ability to isolate, but then if it's a longer trip, you got to stop at rest stops. You got to expose yourself to what might be in those restrooms, the people in the eating, the food courts, whatever. CDC says if you can stay home, stay home. But a lot of people are talking about some of the mental, the emotional effects of the pandemic and being isolated, being quarantined. Now I can't even take my summer vacation. We've all seen pictures on TV of people going to beaches. Some have masks, some don't have masks. Probably not going to be in too much danger spreading it out in the outdoors as you would be inside. But if you stay plugged in enough to the CDC and the news, you won't go anywhere. But you've got to balance that in your own life with the emotional burden of never getting away, never visiting grandchildren, etc. Next slide. So where's it all going? Well, as I say here, pick your oracle. Are we going to get a surge in the winter? If you look at some of the models, the predictors, that curve, which has been coming down and down and down, you look out to October, you're starting to see it go up again. But those are just predictive models. These are the same people, I hasten to remind you, that said we were going to have 100 people in our hospital on ventilators, and that never happened. So we don't know if that's going to happen. A lot will depend on how well we do with social distancing, with masking and face washing. The race really is on for the vaccine to be developed and for antivirals to be effective. We've been using remdesivir here and still do. It's got it's shown a lot of promise in people that are really, really sick. Of course, it's only intravenous at this point. Will we ever have something like Tamiflu for coronavirus that you can take orally? Don't know. Don't know yet. Will coronavirus, SARS-CoV-2, burn itself out like its cousin SARS-CoV? Well, you never know. Viruses sometimes just kind of lose their punch, but it's unlikely. We know that this virus, COVID-19, is more easy to spread because of the upper respiratory predominance rather than SARS, the first SARS, and it was more lower respiratory. And this SARS-CoV-2 is easier to spread before people have symptoms. The first SARS, people got sicker. Most of the spread was from people that were really ill and harder to isolate people before they get sick. So probably not going to burn out, at least until we have a vaccine. Next slide. Been reading a lot of medical literature, reading a lot of articles in the newspapers, but an article that really struck me was one I just read last week from the July issue of National Geographic, written by a science writer named Robin Marantz Hennig. And the article was, why weren't we ready for this virus? And there's been a lot of speculation about this, but I thought her comments were thoughtful. She wrote a book in 1993 called A Dancing Matrix that predicted the pandemic. There were other books that joined this group later on, one called The Hot Zone, a couple of years later, talking about Ebola, coming plague, and something more recently, spillover, just a few years ago, highlighting what a lot of these diseases do is they are transferred from animals to humans, what we call zoonotic or zoonotic. Next slide. I'm not going to read all of this, but the point she makes here is that even back in the 1990s, the doomsdayers of the day were saying, we got problems here. We got climate change, massive urbanization, moving humans closer to farm and forest animals as we reduced the habitat for the forest animals. And these animals were reservoirs of viruses. And we're going to see these microbes unleashed that we've never seen before in people. And on top of that, our economy is more increasingly global. International air travel is increasingly easy. We've got war, we've got famines, we've got people, refugees moving from place to place. Some of these killer pathogens are going to spread more easily. This is what they were saying in the 1990s. And she eerily says here in this article, 2020, does this sound familiar? So why weren't we ready? Well, she says the answer is complicated. Next slide, please. Part of it is that we suspected a lot of pandemics, and it was sort of like the boy crying wolf. A lot of them never came to pass, at least not here in America, except for AIDS, of course, which was global. A lot of the epidemics we thought were going to rage through here never went as global. We talked about SARS in 2003, pretty much stayed in Asia. Yeah, there were cases in Toronto from travelers from Asia. MERS in 2012, that's Middle East respiratory syndrome, never really left the Middle East. That's still around. Ebola in 2014, we prepared for it here. We had donning and doffing drills here. We had special isolation rooms down at a hospital at the University of Pennsylvania. We were prepared for it here at Chester County as well. Pretty much stayed a West African scourge. And what she says here, we kept watching ourselves dodge these bullets. So we kept saying, this is never going to be our problem. This is somebody else's problem. We don't ride camels. We don't eat monkeys. We don't eat bat soup. We don't play with civet cats in wet markets. This is an Asian problem. This is an African problem. It's not going to be an American problem. Next slide. She calls this othering. We've othered the threat for decades. And with it, she says, we're othering away our safety because we're still doing it. Reading about these older epidemics, about these viruses that were supposed to affect us is enlightening. But COVID is the first thing, she says, since 1918. This has, and I love this phrase, I don't love it, but I think it's a good description, a ferocious mixture of transmissibility and lethality. So she closes the article by saying, we almost learned the right lessons 30 years ago, but we ignored them, and maybe this time. Now with COVID here, the prediction has become reality. Maybe the lessons will stick. Of course, that all depends on whether you buy into or believe is true those assumptions about climate and deforestation, loss of habitat, and so forth. Next slide. So can we really control this emergency of the emerging viruses? As I say, will addressing the underlying causes help us? We don't know, but we have a lot to lose if we don't do it, and a lot to gain if we do. So we'd like to move bad storms back to being much less frequent than they are. I've heard people talk about some of the rainfall we've had in recent years as we're having 100-year storms every 2 years now. Well, COVID-19 has been compared to the Spanish flu of 1918. That was supposed to be the 100-year pandemic. Let's hope COVID doesn't become anywhere near like the 700,000 deaths of that. That's what we want to happen, and not let it be just another of these every few years occurrences like the storms. Next slide. People talk a lot about Christmas in July when they're having sales. This year, I'm talking about Advent in July. And with apologies to non-Christians, Advent is the 4 weeks before Christmas, and it's a season of longing, a season of waiting. But we're changing our waiting now for the vaccine, not so much for Christmas, but there's an Advent hymn that some people know that has the line, "Even so, Lord, quickly come, and the night shall be no more." We want the night of COVID to be no more. We want the night of health and healing, the light of health and healing to come. When we were planning this seminar, we talked about it being the Wednesday of the week of June 22nd, but I didn't realize till just this morning, without time to put it in the presentation, that today is June 24th. And June 24th is an interesting day for the confluence of social justice and infectious diseases. Many people don't know it, but on June 24th in 1763, there was something called Pontiac's War going on in this country. And Pontiac's War was after the French and Indian War. It was an uprising of the local Native American tribes, the indigenous tribes, against the British who had defeated the French. And there was a particular siege going on at Fort Pitt in current-day Pittsburgh. And on June 24th, 1763, they had this idea, let's try to decimate the Indians by giving them blankets and handkerchiefs from our smallpox ward. And they did. And they deliberately tried to spread smallpox as biological warfare to these indigenous populations. Now, we're not really sure if it worked, but it was a really nasty thing to do. But I just couldn't help noticing that this day in history was one where infectious disease and social injustice intersect. It's also the day that Champlain in 1604 discovered the St. John River in what is now New Brunswick. He named it after St. John the Baptist because Catholics will know today is also the feast of St. John the Baptist. Champlain was known for his social justice. He encouraged intermarriage between the French colonists and the native populations to create a race of smart, strong people that they called the métis, the mixed people. Anyway, June 24th, an interesting day in North American history. Next slide. Speaking of smallpox, smallpox vaccine is something, and smallpox disease is something, a category I call vaccine-induced amnesia, because prior successes we've had can lead to forgetting. So growing up, my kids might ask, what's that scar on your arm? As you can see pictured here in the upper right-hand corner, a lot of people of a certain vintage will have. Because mom's got the same scar, and Aunt Rosie has the same scar. What is that? Well, we told them it's smallpox. What's that? Well, it's a disease that used to be a scourge, but isn't anymore. We controlled it with a vaccine. I asked another question. There was a kid in my class who had a brother that walked with a funny limp and had this metal thing on his leg. And my parents said, well, he had polio. And I had the luxury of asking, what's that? The luxury because I had gone to our local school on a Sunday in 1961 and consumed a sugar cube with a pink liquid on it that was an oral Sabin polio vaccine. So the point here is that because of public health improvements, and especially in this case, immunizations, yesterday's scourge can become today's and tomorrow's Wikipedia search. And we can only hope and pray the same thing happens for COVID. So that's the end of my presentation, and I'd be happy to answer any questions. Marie, as you always do so well, can you tell us what's come up in the chat? And maybe other questions come up additionally?
Hi, Rick. So far, we don't have any questions that have come up in the chat. So you may want to take a few minutes to allow people to start to put their questions in.
Okay, that's great. If any of you have any questions, if you want to chat them up, we can take a verbal oral question. It's a little bit more complicated to unmute and remute, but we can do that if we have to. If you have any questions, be happy to take them now. I think we just saw one hit the list there.
Yes, we're starting to get them now. Are there any other preventative measures that we should be taking as of right now?
And I'll also say that I know that a couple of our physicians were going to be joining the call either on Zoom or on the phone. So I would ask Dr. Strohs or Dr. Manny or Dr. Lappin to help weigh in as well. I'm sorry, read that question again.
Absolutely. Are there any other preventative measures that we should be taking as of right now?
Well, I think the preventive measures are the ones we've heard about pretty widely in the public health advice. Social distance, especially now as we're due to go green in 2 days in our part of the state. Social distancing, face coverings, hand hygiene, the travel precautions we've talked about already, being careful where you go, knowing what's happening at the location you're going in terms of what's happening there. If you're traveling in the South where the disease might be spiking, might be a little dicier if you can believe the data. Again, do the case counts really reflect what's going on? But until there's a vaccine, the only things we can do are to just be as careful as we can to make sure that if we're sick and if we have symptoms of illness that we don't go to work, that we stay home until we see what happens, call your doctor, especially if they're typical symptoms. If you show up at work and you're screened with symptom questionnaires or temperature screening, you'll be sent home if anything shows up. But just to be really aware and cognizant of what the symptoms are. I don't think there's anybody that doesn't know what they are now. The coughing, the respiratory symptoms and fever, even the GI symptoms, and then the loss of taste and smell. But do as much as you can to prevent it by controlling your behavior. I don't know if that's the satisfactory answer, but that's the only answer I have unless somebody else wants to weigh in.
What are your thoughts on company coffee stations? We closed our coffee stations in March.
Whether it's a company coffee station or the proverbial water cooler, it's all about distancing. You can do whatever you can do as long as you're able to maintain the distance. The other problem with coffee stations is the shared handling of equipment, who's touching the coffee maker. And again, you don't always know who might have had a below the nose moment recently. The chances that they have it and are going to spread it are low because the prevalence is low and because you screened them on the way in. But again, think of the hierarchy of controls. Add as many levels of control as you can. I think a coffee station, I mean, people have taken away salad bars. The local health food store has taken away its fresh food counters. We don't have our salad bar in our cafeteria anymore. The more opportunities there are to be around people in a close setting and to spread droplets and aerosols onto objects that may be able to spread it to others, the greater chance there is to spread. So I think coffee stations are probably a good thing to make go away at this point.
Should we start using the same precautions for influenza as well when it comes to fans and other airflow items?
A great question, and that question actually came up on one of our board calls recently. And the answer is these precautions are the same ones that we use and should be using for flu. We haven't been as universal with face coverings, of course, or distancing. We did a presentation 11 years ago for H1N1 when we thought that was going to be the bad flu. And if I pulled up a slide from that presentation, you'll see references to social distancing, to face coverings, to the vampire coughing and sneezing. It's all the same. It's a droplet and aerosol spread illness, so it's the same thing. We're hopeful that because of COVID-19, the behaviors that people have adopted because of COVID are going to lead to a better control of influenza this year. We also think there's going to be more compliance with recommendations to get the flu vaccine. But yes, definitely, the behaviors that you utilize to control COVID-19 are the same ones we're going to use in the fall to control influenza.
We're getting lots of questions if mask, cloth coverings end when we go green. Do you have any thoughts on when use may not be required in the workplace?
I don't think going green should tell us to lower our guard with respect to masks. I mean, if a restaurant goes green, most of them are saying now, wear your masks into the restaurant, to your table, and take them off when you're ready to eat. I think when we go green, the masks still need to be in place because the disease is still there. I don't think green means the risk is gone. It means that we're at a lower level of precaution than we were at yellow or red. The disease is still circulating. Masks should still be in place as long as the disease is still circulating, especially now that we see it spiking in other states, and especially since at least the best models we have now predict there could be another uptick in the fall. While it's still circulating, masks still need to be in place. Unless you're in your office alone or home with people you've been with all along. Some people have quarantine buddies that they know that they've been controlled for a certain amount of time, and they're now expanding their bubble to people that have been similarly controlled. It's riskier, but again, if you keep those graphs in mind, we're not throwing all caution to the wind. Those people are still wearing masks when they go to the supermarket or go to get gas. But if you want to take your mask off in a certain expanded bubble, that's an individual decision. I can't say to do it because it's a lower level of protection, but I know that people are doing it.
What are your thoughts on mask types in the workplace? We were using half mask industrial respirators only. We're now allowing non-surgical face masks. Any other mask types that would be suitable and available?
It's mostly about what the risks are and what needs to be covered. So in healthcare settings, if we're doing procedures that create aerosols, such as endoscopies, putting a scope into somebody's throat, or a bronchoscopy, or you're administering, or you're putting a tube in somebody's throat and they might cough and generate an aerosol. It's masks and eye covering as well. The eye covering might be goggles, or it might be a face shield on top of a mask. In a workplace, where you aren't generating those aerosols, the main thing is to cover your nose and your mouth with a face covering. Doesn't have to be a surgical mask, but something to cover the nose and the mouth unless there's a risk of aerosols being generated that could get into your eyes.
We did receive a private message asking if copies of the slides and presentation might be available, with the comment that they were excellent, as is this webinar, and a thank you.
Oh, well, you're very welcome. Thank you for that. And yeah, we can make the slides available. Sarah, I'll get you a copy and you can make that available. We'd also be able to do meetings with individual companies that weren't able to join today. We'd be happy to go through some of this, probably not the whole thing, but we'd be able to do presentations for individual companies if they wanted. But thanks for the call.
We have one more. For a non-health employer, who should do the temperature screenings?
Well, it doesn't have to be a healthcare worker. We have the luxury here of using healthcare workers because when we initially couldn't do elective surgeries and we didn't have patients coming to the hospital because they were afraid of COVID, we had a number of employees that were available. They weren't in the operating rooms working. They weren't on some of the nursing units. We had people working on the COVID units, but not on the non-COVID units. So we were able to tap nurses and other healthcare professionals to do the temperature, but it does not have to be a healthcare professional. The screening devices, you're just pointing a device at somebody's temple and taking a reading. This is something that parents do now with their young children when they're checking their temperatures. So it does not have to be a health professional. You just have to read the instructions and just start doing it. And it's pretty, I don't want to use the word idiot proof, but it's pretty easy to do.
Other than some thank yous, Dr. Donze, that does seem to be the last question for now.
Oh, well, that's great. Well, thank you all very much for your attendance and your attention. Again, this is evolving. We are probably going to do something like this again in a couple of months, maybe in the fall, once we see what's happened. And keep your questions coming through email, phone calls. Happy to meet with you. Happy to talk and answer any questions. And again, as the advice evolves, if you don't like the weather in the tropics, wait 5 minutes. The COVID advice is probably going to change as well. Thanks again. Thanks again to Marie and to our staff. Any other comments from our physicians on the line? Did I say anything that needs to be countermanded here or reversed? I'm going to take that as a no and get out of Dodge while nobody said anything. So thanks again, everybody, and have a safe summer, and we'll be talking. Bye-bye.